Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientists monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host for today's webinar. Today, Dr. Fritz Henn will present Bipolar Disorder. The Brain and Behavior Research Foundation is committed to alleviating the suffering caused by mental illness by awarding grants that will lead to advances and breakthroughs in scientific research. The Foundation is the largest private funder of mental health research grants. Since 1987, the Foundation has awarded more than $360 million to fund more than 5,000 grants to more than 4,000 scientists around the world. 100% of all donor contributions for research are invested in our grants to scientists who are working to find breakthroughs in disorders such as ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, addiction, schizophrenia, depression, OCD, and post-traumatic stress. I'm delighted to introduce Dr. Fritz Henn. Dr. Henn is Professor of Psychiatry at the Icahn School of Medicine at Mount Sinai in New York. He's a founding member of the Brain and Behavior Research Foundation Scientific Council and is the 2014 Foundation's Colvin Prize winner for mood disorders research. Today's webinar will begin with Dr. Hess's presentation. This will be followed by a question and answer period. To submit your questions, please use the questions tab on the control panel on your screen. Please feel free to submit your questions throughout the presentation. Following the presentation, I'll present as many of your questions as we have time allotted. And now, I'm pleased to introduce Dr. Fritz Henn. Fritz, the floor is yours.
Thank you very much, Jeff. Hopefully you can see my first slide.
Dr. Henn, if you can click on share screen.
Show my screen, yes,
exactly.
I can.
Perfect, wonderful. Thank you, you're good. Thank you.
Okay, and that small little house in the front is actually the lab where much of this work was done. Very tranquil, and it doesn't look like we should understand anything about mania from this. This is part of Cold Spring Harbor Labs, which is one of the great research laboratories in the country, and I had the pleasure of working there a few years ago. Okay, let's get going. If we...
So if you can click on the slide, anywhere on the slide.
Okay, here we are. Now, we're going to talk about manic depressive disorder, and manic depressive disorder is much less common than plain depression. About 1% of the population suffer from mania and depressions, the bipolar affective disorder, compared to about a lifetime prevalence of 16% of the population with unipolar depression. The prevalence of unipolar depression is very high. It's almost 1 in 5 people will have it, and the 12-month prevalence, as you see, is 6.7%. And the 12-month prevalence for really severe depression is still 2% of the population. So this is one of the great causes of disability in the country, ranking equal to or greater than such things as heart disease. Manic depression is much less common and is in some ways a little bit more difficult to treat. The remission rates for depression, if you don't do anything, are about 30 to 40%. With good psychotherapy, you can get about 50 to 60% of people better. Standard antidepressants will get up to 65 to 70% of people better. Severe depression, you can get 85 to 90% better with ECT, and some of those last 5 to 6% will respond to different forms of deep brain stimulation, so that there are a variety of treatments staged to treat depression. In mania, we have fewer treatments, and it's a little bit more difficult. In bipolar disorder, almost all the patients will remit initially after a manic episode, even without treatment. On average, such an episode would last 3 to 4 months, and compared with depression, which would last 4 to 5 months. In those people who develop mania, about 15% of them will show rapid cycling. That is, they will move in their moods from very, very high to very, very low several times in a single year, sometimes 4 or 5 times in a single year. And that's extremely disruptive. It eliminates any chance of continuing to have a career. It is devastating to these people. Essentially, all the patients who suffer from bipolar illness with mania will have 1 or 2 relapses at least in a lifetime, and many will have sequential relapses. So we need treatments that will prevent the relapses. That's very, very important. The treatments for mania started with lithium, and lithium is still, in my view, the most effective drug we have for this disorder. Lithium was actually discovered in an almost unbelievable way. Mogens Schou was a Danish psychiatrist, and his brother lived in Australia and had mania, and for some reason took lithium salt and got better. And Mogens Schou realized maybe there was a cause and effect here and began to study lithium in mania, and found that indeed lithium really is effective in reducing manic episodes and ending them. And in fact, epidemiologically, in areas where there's lithium in the drinking water, you find less mania. And these very idiosyncratic observations actually led to one of the most effective drugs in psychiatry. The problem with lithium is it can be toxic if it's in high doses. So you need accurate blood level monitoring, and it needs to be done regularly. And that, of course, is a hindrance to patient compliance, because it means they've got to come in and have blood tests repeatedly. And that's just very, very important, and you really have to stress that when dealing with manic patients. If lithium is not effective, it was found that sodium valproate sometimes works. And in both the cases of lithium and valproic acid prophylaxis, you can add an atypical antipsychotic, such as olanzapine. And that can be very helpful in bringing down a manic episode more quickly. The problems with the atypical antipsychotics are there are a range of side effects. One of the worst with chronic use is weight gain, and this can be severe, so it has to be monitored and watched carefully. There are newer drugs which are also effective and appear to be effective about the same rate as valproate. And in very difficult cases of mania, ECT can be used. So there are a variety of treatments that we can use. And in general, we can get control of a manic episode in 3 to 5 weeks. One of the major problems is reoccurrence. And that's why you need long-term lithium prophylaxis in people who have one manic episode, because this is a disorder which reoccurs in irregular time periods, and you can even see rapid cycling, moving from depression to mania within days and weeks, and this is incredibly disruptive to a person's life. So there is a need to keep chronic mood stabilizers on board and try to control the cycling in manic depressive disorder. This is going to be a case report of a very typical manic case. It's actually a case that in some aspects I saw 30 years ago. And it involved a 44-year-old dentist who began showing increased energy and sleeplessness over a period of about 4 to 5 days that his wife noticed. And about day 3, he made completely out of character sexual advances towards one of his dental assistants. On day 4, he left the office early and went for a ride in the country, and when he came back, he was convinced that God had spoken directly to him. He was very agitated. He felt he had a mission to save the world, and he was hospitalized within about 6 hours of this. It was the first episode of mania, and he responded within 3 weeks to lithium treatment and a small dose of an antipsychotic drug. Over the 5 years that I followed him on lithium, we kept his blood level at about 0.8, and he never had another episode and functioned well as a dentist. So it illustrates that in bipolar illness, if you get a good response, it's a very controllable illness. Now, what happens in the brain and what happens to our thinking? And I want to go back to a cognitive model of depression that Aaron Beck developed years ago that was the basis, really, of cognitive therapy. What Aaron said is that there's an event that you distort. In the case of depression, you distort it in a negative way. That creates an emotion, which is usually anxious and some depression, and it indicates that it leads to a behavior that suggests a sort of hopelessness or helplessness. And that's maladaptive, and of course that leads to bad outcomes, and you cycle around and around until you've dug yourself a big hole. I think we can think about mania, and this is my interpretation, in a similar way, except going in the opposite direction. You have a cognitive appraisal that's distorted, and it's made too good. Things are looking great, and you have great abilities. You get excited and energized. You get a little anxious. And then you are somewhat grandiose and try to do things which are really out of the realm of possibility. So it's maladaptive behavior, but you don't learn from it. You just keep cycling around, getting more and more excited, energized, and unfortunately maladaptive. And then you're in a full mania. Now, how can we understand this in the brain? And this is a slide which is modified from some work that was done probably about 20 years ago by a group in Colorado, and I think it was felt at the time, and I still think it's true, that this is a very accurate description of how the brain develops a kind of change in affect or depression. And what it says is that you assess stress mostly in the cortex. That's the medial prefrontal cortex up there on the right-hand side. And that sends signals to an inhibitory neuron, which then inhibits, in this case, the output of serotonin in the dorsal raphe nucleus. And so you get less and less serotonin. That is one aspect leading to depression. We developed a rather good animal model of depression based on Beck's ideas, and it was called learned helplessness. And we used that model to create strains of animals through genetics that were either congenitally helpless or congenitally really supernormal. And we compared their brains to get some idea of how this looks. And we came up with this little structure that I have never even heard of called the Lateral Habenula, which seemed to control this system. And when we investigated this in a little bit more detail, we found out that when the Lateral Habenula turns on, it really depresses not only serotonin, but norepinephrine and dopamine. And very few people at the time that we were doing this work had heard of the habenula, and to our surprise, a very important paper came out from the NIMH. Actually, it was the National Institute of Eye Research, which looked at the habenula in monkeys. And the point of this paper was that the habenula gets most active with the most noxious kinds of stimuli. Punishments or absence of reward when rewards were expected. Those were the things that turned on the habenula. And what did the habenula do? Well, it turns out that this cartoon summarizes a lot of work by us and the other labs that suggested that the habenula controls dopamine, serotonin, and norepinephrine throughout the central nervous system. And its inputs come from the hypothalamus, which is the area that is involved in stress and the cortisol response. It comes from a tract going from the hippocampus through the amygdala and the basal nucleus of the stria terminalis. This is the tract that really mediates fear and anxiety. And it comes from the medial prefrontal cortex, where we sort of put all these thoughts together and create a sense of either comfort or discomfort, and can feel either depressed or elated. All of these feed into the habenula, and the habenula, if it's activated by all of these, then turns off all of the catecholamines. So you lose your sense of reward, you lose the energy from adrenaline or norepinephrine, and you lose the serotonin response. And that is how you get depressed. Now, it struck me that it's possible that the exact reverse of this takes place, and that leads to mania. And in order to get an idea of this, we wanted to see what happened in a real person if depression were suddenly introduced. And you can do this in people who have depressive illness, who are well. If you give them a tryptophan challenge, you immediately cause a decrease in serotonin, and these people develop all the signs of depression, which you can then immediately reverse by increasing serotonin levels again. Well, this was done in an experiment that no one ever referenced, which we found, and it was done in one of the great imaging centers at the Wellcome Trust in London, and I trusted their data implicitly, but I found this paper that no one had ever paid any attention to. And that little yellow spot in the middle is basically the habenula activated as this person got depressed. So it shows that this mechanism actually holds in humans with a history of depression. So maybe there's something to this. And we wondered whether the inverse couldn't really give us something about the anatomy of mania. Could it be that if the stress level was down, your medial prefrontal cortex was misassessing things and finding them all better than they really were, and you had no fear input, that you would essentially turn on all these systems. Instead of turning them off, you would now put out too much dopamine, having a great sense of reward, too much serotonin, too much noradrenaline, giving you much more energy, and giving you, in the end, grandiosity. And couldn't it be that this is really how mania gets started? And if that's the case, then maybe we can start to understand at the cellular level how we might deal with that. And here's a picture of a cell, and I'm going to go back to depression and one of the treatments that you may have talked about at a previous webinar, namely the use of ketamine in depression. And I'm going to try to show you how this, at the level of a single cell synapse, and this is what this picture is. On the top is the presynaptic area, and on the bottom is the postsynaptic area, and that dark blue blob to the right-hand side is an astroglial cell. And if you're going to watch the V-glut little thing, and you will see that they will load up. This cell loads up, and then it sends out glutamate. Glutamate gets taken up into the astrocytes, but it also hits these postsynaptic receptors, especially the NMDA and AMPA receptor. And what it does in the case of the AMPA receptor, this is the one that matters when things go wrong, is it normally increases the spine density if you get if you get ketamine acting, it activates a system that makes more nerve endings. You look at the left-hand side, you see more nerve endings than on the right-hand side. The left-hand side is after ketamine. And one of the things I've wondered about is, couldn't this also be what goes on in a case of mania? If you've ever seen a patient with ketamine intoxication, you realize it's very close to a manic state. They're often hallucinating, they're hyperactive, and they've lost their sense of reality, which makes ketamine obviously a very dangerous drug to use routinely, and it has to be done very carefully when it's used to treat depression. That it may be that controlling the number of nerve cell endings is really what, in the end, determines whether we're depressed, normal, or hyperactive and manic. So all of these things go into learning, memory, and plasticity. Now, I'm going to show two very technical slides at this point and try to explain them because they give an idea of how we might think about treating both depression and mania in the future. And they involve this model that we created, the learned helplessness model of depression. And we had two genetic lines. One line was resistant to helplessness. The other line was very susceptible to helplessness. And we asked the question, what is different in these two lines? And the way we did that, this is a confusing slide, and I'm going to walk you through it. What we basically did is we fed one line a food chow with N14 as the nitrogen. The other line had a food chow with N15, so that the proteins, all of the proteins in these animals, had slightly different molecular weights because of the difference in the isotope in the food that they ate. We then took helpless animals, non-helpless animals, and took their brains and looked at what was different, what proteins actually were different, where the N15 amount was different than the N14 amount. And we really found basically one major protein that was different, a protein called beta-cam kinase 2. And we found that in the depressed animals, it was simply higher. And you can see that down at the bottom under section H. You just look at the blob under beta-cam kinase, and you see that the blob is higher. And in all of these graphs, basically, that's all this is really saying. It's saying that this one protein seems to be higher in the depressed animals. Now, we wondered if this is true, could we reverse this by eliminating the beta-cam kinase using a molecular form of RNA that inhibits the translation of the beta-cam kinase DNA. So namely, we were just shutting off the apparatus that makes this enzyme. And when we did this, we were able to reverse completely the depressed mood in these animals. Now, what we haven't done, and what I'm wondering about, is if we overexpress this in a normal animal, not a depressed animal, would we get a manic-like picture? And I don't know the answer to that, but my guess is we would. And the reason is that that protein controls the activity of that little structure, the habenula, that I talked to you about, and the overexpression would allow too much dopamine, too much serotonin, and too much norepinephrine to act throughout the whole brain. So let's leave the science for a minute and think about treatment approaches if we have a new patient with bipolar illness. And I think that even today, one should begin with lithium and establish stable blood levels. And you've got to make sure they're in the therapeutic range. Around 0.8 is a good place. If after 3 weeks to 4 weeks you have no response, I would usually add valproate, leave the lithium. Some people would switch. I would just add the valproate in a sufficient dose and see if in the next week to 10 days we didn't achieve control. I might also have added an atypical antipsychotic earlier on if the patient was very agitated or very aroused, in order to just get some behavioral control during this period when we're trying to get rid of the mania. If those don't work, then move to some of the newer drugs, like Lamotrigine or Lazodone. The data on this last one aren't as complete, but both of them seem to work about as well as valproate, and it's possible that they may work in some patients who don't respond to any of the other drugs. So there are a variety of treatment options that we can use. And once one gets control, one hopes that one can convince the patient to go on to a chronic prophylactic regimen, ideally with lithium. Treatment has to be assessed in terms of how the person's able to function, how they focus on a topic, and their sleep patterns. Sleep patterns are very important and a good clue in mania. And I think that in rare cases, you sometimes, again, might want to go to ECT if you'd get no response and you have a very, very agitated patient. So under those circumstances, I think there's a kind of ladder of treatments that one can go through, beginning with lithium, adding antipsychotics, switching from lithium, or adding valproate to lithium, and ending up with ECT if necessary. And you should be able to control almost all manic patients. In summary, then, this is a reoccurring illness, and that's one of the real problems with bipolar disorder. It reoccurs in some people very frequently if it's not checked, and it is lifelong pretty much. It requires immediate treatment and long-term prophylactic treatment. Getting an episode under control is not enough. You need to avoid the reoccurring episodes. Lithium, as I've mentioned several times, still remains the first line of treatment. It requires blood level monitoring and long-term thyroid monitoring. And you want a patient who has the ability to follow directions or has someone who can make sure that the dose is right, because high doses of lithium can be very toxic. So you want to keep it in the therapeutic range. Atypical antipsychotics are very useful in the manic phase. I try to get patients off of these once they're in reasonable control. I think you sacrifice a little bit in prophylaxis by doing that, but you gain by not having the side effects of weight gain, which over time can lead to heart disease. And since this is a lifelong illness, I try to use antipsychotics only when they're necessary behaviorally. Valproic acid can also be used chronically, and that pretty much sums up the treatment options that we have. The newer drugs that I mentioned can also be used if valproic acid and lithium are not effective. The data is not as good. They seem to be about as effective as valproic acid, but whether they can generally treat patients who haven't responded to either, I don't think there's enough data in the literature yet. So that is the end of the slideshow, and I would be happy to answer any questions.
Fritz, thank you very much. Very, very clear explanation of some complicated science, and certainly an explanation of some of the key clinical points in treating bipolar. So thank you. One of the questions relates to what you spoke about at the beginning, which is rapid cycling. And I'd like to ask you to speak a little bit more about what happens in rapid cycling and what are the best ways for families and patients to try to get that under control.
Well, that's probably one of the most disruptive things that can happen to a family, because you have a patient who may be overly energetic, grandiose, making wild plans, and very suddenly shows all the signs of a major depression. Hardly moving, not talking much, and often these people are not sleeping, and not sleeping at all, and they will switch back and forth between these states. And that's really, really disruptive. I think in most serious rapid cycling cases, I have hospitalized the patient till we broke that.
Okay. And the medications used are the same what you described.
Right. And what you would start with the lithium if you could. If the patient were amenable, you would use the antipsychotic drug right away, just to quiet things down, and then try to get a lithium level that was decent, and then see where the patient ends. If they end up in a depressive situation, then you might want to take that antipsychotic drug away and just go to lithium and see if they come out of that before adding an antidepressant, because an antidepressant will tend to throw them back into the manic phase.
Right, right. And you spoke about sometimes when the illness begins at a younger age, it could be a more difficult course for the person. Often, there are a number of people who respond very well to treatment and go on and really are able to live full, healthy lives with treatment. But there are some people who really don't respond well to treatment. What do you recommend to those people and to their families?
Yeah, that's really, really difficult, because obviously what you initially said is there are a number of people who do very, very well and are able to have enormously productive professional lives and go on as my dentist did. There are cases where you just can't achieve that kind of control. And in those cases, obviously, you start looking at different treatment alternatives. Perhaps adding valproic acid to the lithium and seeing if that combination will help. And it requires a pretty intense doctor-patient relationship, because you're going to be trying things in which there's not a lot of data, and the person is very volatile, and that's very difficult. Those can be among the most difficult cases to treat.
Right, right. The other thing that often could be difficult is if the person with the illness really minimizes the level of illness that they have and minimizes the need for treatment. Are there any suggestions you could give how to proceed with that?
That's often the case in mania. They think they're flying on top of the world. They've got it all together. They understand things you don't understand, and you're simply too dumb to see it. And that can be extremely difficult until you get some medication in. And under those cases, sometimes it's necessary to use a sedating antipsychotic medicine just to get them down enough to get them started on the lithium. That can be just very, very difficult, because they're feeling great. They think they understand stuff and you don't. And they wonder why everybody's giving them trouble. It's a very tricky therapeutic situation, both for the families and for the physicians.
Yes, basically one of the symptoms relates to not being able to identify that they have an illness and need help.
Absolutely. They're convinced that they're on top of the world.
Are there warning signs that families can pick up on even before a full-blown episode occurs?
The data is not ironclad. My own clinical assessment is that often sleep difficulties will precede a full-blown episode, and that if you see some sleep problems, then and especially if there's no good reason, there's no new stressor in the life or nothing's happened. Even if there is, it can be a signal something's going to happen. But I think that sleep disturbances sometimes are the first sign that something's going wrong. They're not a clear indication that it's going to be a bipolar illness by any means or a depressive illness. But if there's a family history of that sort of problem in the family and there's sleep problems, then I pay a lot of attention.
Okay, so that's important for people to realize. And once the person has been diagnosed with bipolar disorder and are doing well, stabilized, at that point, something to look for is a change in their sleep habits again, as
Right.
a warning sign that there may be a relapse.
That something is coming, yes. Then it's definitely a sign.
Right.
Yeah, it's the first episode that's so hard to really know. Is the person just a little high, or is this really the start of a serious illness?
And in a first episode where the symptoms are depression, where the person is experiencing a depression, is there any way for the family, for the clinician, for the person to be able to know that this isn't unipolar depression, but potentially a bipolar depression?
The only really useful way to know that, in my mind, is if there is a family history. Without a family history, it's very hard to say. But if there's a family history, it's usually going to be the same kind of an illness, whether it was a depressive illness or a bipolar illness. At least there's a tendency that way. And so I think you have to talk to the family, even if it's just mild hypomania, somebody wasn't really ever hospitalized and sick, but they have low moods and high moods, then you start to think about bipolar.
Okay, so the family history is key. That being said, just because somebody has a family history of it doesn't mean that they're going to get it, but
That's right.
it can increase the risk. It could increase the risk.
It increases the risk, and it increases your suspicion that this is something that might be developing.
Right. I want to get to some of the science about the habenula. I know you've done a lot of work on it. What do you see as a potential treatment that may result from your work in this particular area?
Well, one of the things that we have started to study is the problem of treatment-resistant depression, where a person goes through everything: cognitive therapy, interpersonal therapy, mindfulness training, antidepressants and lithium, ECT, and they just don't get better. In those cases, we have considered using deep brain stimulation in the habenula, and there aren't enough cases yet to say whether this is going to be really useful, and I find it really the treatment of very, very last resort. But we do have cases where people who had very severe, recurrent, almost continual depressions, a few cases in which we've done deep brain stimulation of the habenula, and it's resulted in complete remission. And one case is particularly noteworthy. It was a case done in my old German institute. I used to work in Germany, and This woman had a very, very severe depression. I knew her, and after I left, they decided to do the deep brain stimulation. And she was well for, about 15 months, I think it was. And like a good German, she didn't use her car. She took her bicycle to the supermarket, and she got into an accident. And she was taken into the ER, and the trauma surgeon saw this strange thing under her chest wall and took it out. That was the battery that drove the stimulator for her deep brain stimulation. And within hours, she was psychotically depressed again. It was put back, obviously, immediately as soon as we found that out, and started, and within about 36 hours, she was back being totally normal. So that showed us that if you get it just right, the deep brain stimulation of the habenula can be useful in these very, very chronic depressions. Now, could you ever use them in mania, turning it down? I don't know how to do that.
Okay. So just for people in our audience who aren't familiar with deep brain stimulation, it's something that's been used in Parkinson's disease. It has been looked at for depression. Could you say a little bit about what that process is?
Okay, that's basically, let's think about it first in Parkinson's disease, where there's a long history. In trying to understand the disease, there was a clear anatomy that was developed. The details of that are not important, but there seemed to be a focal point. And then the idea was, if there's a focal point where there's not enough activity in the brain, if you actually put an electrode in the brain and stimulate at the rate that that would normally be stimulated, would you restore function? And that's seen. And there are cases of other muscle atonias, which are very, very dramatic, in which a lesion in the brain can be seen using imaging, and if you put an electrode in there and get that area functioning at a normal rate of charge, all of the neurological manifestations are changed. And that same procedure was tried in depression. Helen Mayberg, using a different target than the habenula, somewhat downstream of it, has done probably the most extensive studies in depression. And a group in Canada has continued some of that work. They worked together initially. Now they're doing it independently. And other methodologies of altering the brain, as opposed to putting an electrode in, are being tried now. And it looks as if you understand the anatomy well enough and can localize an area of overactivity or underactivity, you can, using an electrical stimulus, normalize that, and you return function. And that's been seen in a number of conditions, including depression. So, although I think it's enormously helpful in understanding the circuits, I don't think this is really a treatment modality that should be or will be widely used. It may be used in cases in which nothing else helps and suicide looks to be a possible outcome. But other than that, I wouldn't go to DBS, even though we are currently still studying it.
So the information that you've been developing about the anatomy that's involved in depression helps guide where deep brain stimulation, which is obviously a very invasive process, or perhaps other interventions can be useful.
Absolutely. And the question now is, can you do things like focused transcranial magnetic stimulation, which doesn't involve putting an electrode in the brain, but just putting energy into the brain? Can you use that sort of treatment using the kind of an anatomical knowledge that we're getting to modify conditions like depression? And obviously, that's a promising and currently very actively studied area.
I want to move to something that you mentioned a few moments ago, which is the issue of suicide in depression and in bipolar disorder, and ask you to speak about that important issue, because people with those illnesses, if it's untreated, can be at risk for suicide attempt or an actual suicide.
Absolutely, and obviously that's the greatest danger, and that's what families really have to take into account if a person is becoming more and more deeply depressed. There comes a time when you really have to make sure that the person is in treatment and possibly in the hospital, because the risks are real. It happens, and it happens more often in certain groups than others. Elderly tend to be at some risk more than others. People who obviously have firearms around are at a high risk because they can in an impulsive way act. And it's just a very serious problem, and if people have suicidal ideation, I always recommend hospitalization. They're starting to talk about it and think about it. I think it's important to put them into a protected environment.
So if somebody is speaking about suicidal thoughts, this needs to be taken very seriously, similar to if somebody is clutching their chest with chest pain, you're concerned it could be a heart attack, you're taking them to the hospital. This is the same level of concern.
I think you're absolutely right, Jeff. That's exactly it. If people are starting to talk about it, it's a serious problem.
Right. I want to ask you about another issue that can occur with depression with bipolar illness, which is substance abuse and misuse. And I'd like you to speak about how that gets into the clinical picture and what can be done about it.
Well, obviously that complicates the clinical picture terribly, and it often enters the clinical picture because people try to self-medicate. They're feeling lousy, and so they, for example, take amphetamines to feel better. And the next thing you know, they really like amphetamines. Or they find that the narcotic high really takes them out of the painful area that they find themselves in a depression. And then the next thing you know, they're really addicted to a narcotic. And these complicate the entire treatment picture, and they almost mandate hospitalization because you have to have withdrawal and treatment. And unfortunately, people are just trying to self-medicate to ease the pain in all cases, I think. That's how people with illnesses get into it. People with depression aren't going to be out looking for highs. They're going to be looking for relief. And if they're in an environment in which drugs are around and someone suggests amphetamines, then that's going to happen. So it, in part, is dependent on the environment the person finds themselves in. Some people will be in areas where it's kind of hard to get drugs. Others will be in areas where drug use is common, and then it becomes a not uncommon complicating factor in these illnesses.
And a key take-home point is that when this occurs, you need to treat both. You can't treat one without treating the other. They need to both be treated. Yeah. One of the things that people sometimes talk about, and I want to ask you to comment, is the issue of creativity. What's your experience? What does the research show about this issue of that people with bipolar disorder, for example, may be more creative, and treating it can get in the way of that?
Now, getting to some of Nancy Andreasen's studies, obviously there there's a fine line. Hypomania is probably the most productive state we humans can find ourselves in. That is a mania that isn't really clinical, but we're really pushing, and we're turned on by something, and we're really going after it. Obviously, when that cuts over from hypomania to the illness mania, then the creativity is pretty much messed up because it gets chaotic, and people can't control it as well. So mild hypomanic conditions are seen in a lot of artists. I think full mania, it's just about impossible to continue writing or painting in a reasonable way under those circumstances. But there seems to be some association from Nancy's work with the tendency towards mania and creativity.
But once the person gets to the point that they are really having a manic episode, at that point,
it's lost.
Their functioning gets in the way. The functioning gets in the way.
That's right. It just can't be ordered anymore. And you're not going to write great prose, and you're not going to paint great paintings if you're out of control.
I want to ask you about some other, in addition to medication, therapy, etc. Are there other steps people can take if they have a diagnosis of bipolar disorder, for instance, exercise, other lifestyle changes? What do you recommend to people to maximize their health?
I recommend exercise to everybody. I have a daughter who does Ironman triathlons. I think that may be overdoing it, but I think exercise in general has been shown in good clinical studies to be very, very useful. And I think regular exercise has the advantage of both increasing endorphins and using up excess energy. So I suggest that everybody exercise regularly. I don't think you have to be fanatic about it. You don't have to go do triathlons, but I think that some form of regular exercise is something that I recommend to almost every patient who I've seen.
And obviously, being careful about sleep habits is important. Are there other lifestyle recommendations that you make?
Well, obviously, you want to be careful with alcohol. You don't want to be using too much alcohol, and you do want to have relatively scheduled and regular lifestyle in that, bedtimes don't vary by 5 hours, that you're not throwing all night study breaks and trying to get on, especially if you're vulnerable to these illnesses. I think regularity in lifestyle in terms of both sleep patterns and eating patterns is very, very helpful in those cases. And that's most important, obviously, for younger people. Students tend to go into situations where they'll either stay up for 24 or 30 hours to get something done because they had let it go. And that can actually throw you into one of these conditions if you're vulnerable and have the susceptibility.
So an important take-home message is for family members of people who have a history of bipolar disorder, and maybe at some increased risk, should be a little bit extra careful about these lifestyle issues in terms of alcohol use, other substance use, sleeping with a more regular schedule, etc. Probably everybody should follow that guidance, but especially people who might be at a higher risk. Right.
It's obviously straightforward, reasonable advice for all of us. The people at a higher risk can gain more if they follow those guidelines, because they will be lowering their risk a little bit.
Right. I want to ask you one final question. Where do you see in 5 years from now or 10 years from now, where do you see the big change in terms of treatment for bipolar disorder?
Well, I would hope that we could come up with something that would be even more successful as a prophylactic than lithium, although I'm not sure that that's on the horizon. There's no question in my mind that we are going to have ever increasingly effective antidepressants. I think we have drugs now which only work in a moderate percentage of our population. I think we're going to get treatments which will work 90-95% in the next decade. Whether we're going to get something that's more effective in mania than lithium in a lithium-responsive patient, I'm not so sure. In lithium-responsive patients, this is a pretty good treatment, and I've had people who've gone years and years and years with no reoccurrence once they got on a stable blood level and just stayed on it with regular lifestyles.
Certainly improvements in treatments for depression would be a big plus for many people respond to the current treatments. For those who don't, and I agree with you, for many people who are able to respond to lithium and some of the other medicines, they're able to really live full, healthy lives. And the goal is to have that opportunity for everybody.
Right.
So, yeah. Well, Fritz, I want to thank you for an excellent presentation. And just as importantly, thank you for all of your work throughout the years and your ongoing work to better understand these conditions so that we could have better treatments for them. It really has an impact on people's lives. So thank you very, very much for all that you do.
Well, you're welcome. I'm about to retire now. I'm 75. And I think I should thank what started out as NARSAT and is now the Brain and Behavior Foundation, because I think you've added an enormous amount to research in this area for all of us and for all of our students. And I hope it keeps going.
Well, we intend to keep it going, and thank you for those words. It really is important that we continue to have an impact on research and new and innovative approaches to helping people. So thank you very much. I also want to thank everybody for joining us today for the webinar. All of the research we fund is made possible through private donations, and if you'd like to make a contribution, please visit our website, bbrfoundation.org, or call our 800 number, 1-800-829-8289. This webinar has been recorded. If you missed any portion or would like to share it with a family member or a friend, please visit the webinar page at our website. And I hope you'll join us again next month when Dr. Amy Arnston, Foundation Scientific Council member and Professor of Neurobiology at Yale, will present a webinar on prefrontal cortical circuits in schizophrenia, molecular vulnerabilities, and clues for treatment. This will take place on Tuesday, February 14th at 2 p.m. Eastern Time. Once again, thank you all for joining us, and have a good day. Take care.